Hello, today I've seen a patient who has been intubated secondary to airway compromise following an overdose of amitriptyline. So she has a background of there's depression and then she's on antidepressants for it. She overdosed herself. So this was an intentional overdose and she has been intubated ever since. There were trials of extubation but failed because she was very agitated of sedation and then gets very panicky and desaturates. Today we've tried to do another trial of extubation. She also has diaphragmatic paralysis on the left side. That's secondary to brachial neuritis. I'll have to study more about it, how and why this happens. And for this diaphragmatic paralysis, she is on a home setting of like an NIV machine, but it's a different mode on an NIV. So it is called IVAPs. So it's similar to ASV, I was told. I was briefly talking to the consultant about it. So it's similar to ASV setting on the ventilator. That it is a clever method, manages or changes the parameters of the settings to achieve your minute ventilation. Here it is, you fix your alveolar minute ventilation and the tidal volumes vary to achieve that, and you put your maximum of EPAP and then also maximum of IPAP, and it'll try to balance the numbers to reach the tidal volume. In her case, we've put that after we've extubated her and then we put that on. She was still, her tidal volumes were not reaching. Target tidal volumes were like 550 and she was only doing 300, 450. So she was not reaching her tidal volumes and she was also desaturating a bit. Then she started to become very wheezy, crackly, and worsening crackles in spite of giving the furosemide, giving NEDs. So the idea behind giving furosemide is that if she lost the PEEP when we've extubated her onto the IVAPs, if she lost that significant PEEP and then started to have a pulmonary edema due to this. In spite of that, she's not getting any better. We wanted a chest x-ray. In the meantime, had to intubate her. Okay. So the next plan is to get her on a trachea, and we would do it's not a percutaneous trachea, rather it will be a surgical trachea because she's a heavy lady, high BMI, and on ultrasound of the neck, it does feel like she has tracheomalacia as well. And also because of high BMI, her access to the front of neck is difficult. So it'll be the surgical trachea instead of percutaneous trachea, and that'll be by the ENT surgeons in the theatre. So on the ultrasound, we could see that the trachea was compressible. So I quickly had a look at how do we quantify this. So if more than 50% of your trachea is collapsible anterior posteriorly, then that means it is tracheomalacia. So this is not something acute. She must have had tracheomalacia earlier, and this was just picked up, or it's more significant now. So all of these factors are making it more difficult for her while she's in the ITU stay. I'll keep you updated. If you like my videos, please like, share, and subscribe.